this is a question for everyone, but especially for Isaac, since you mentioned the model of HIV care, especially in terms of cost and the way it came down, but also the way that hydroxyurea is much cheaper. I'd like to push a little bit more in terms of models of care because, as you know, MSF pushed for HIV treatment, and we managed to show that to scale up, the only way we could do it was task shifting. Yeah. And I want to ask you about this because I think that hydroxyurea, if it is available, if it is going to be available, it shouldn't be at the tertiary level. Yeah.
I agree, and I think, first of all, the comment, maybe to answer that question, even in the United States and Europe, we made a very catastrophic mistake by thinking that only hematologists can take care of sickle cell patients. In fact, that has actually done a lot of harm to the programs in the United States because there are very few hematologists, and the very few who are trained would rather treat patients with hematological malignancies. Every journalist, every healthcare worker can be trained to manage sickle cell disease. And I think that restriction to hematologists need to be taken away. If you come to use fixed moderate doses that are not very intensive, the evidence will come out, but the evidence will show that actually very strict monitoring of hydroxyurea is not required. However, as Mariane said, it is important to have a kind of a link, and this link can be done using modern technology. I mean, you don't have to have a patient traveling 500 kilometers to see a specialist. I mean, if it can be done by information technology to really address the problem, I think we can bridge those gaps. So I agree with you. In Ghana now, we are about to train sickle cell nurses because we've come to the conclusion, we've got a Canadian government grant to train nurses who have expertise in sickle cell disease. Because in many rural settings, there are no physicians. And who is going to manage these patients? And we are saying that some level of the care can be integrated into primary care. So I agree with you that task shifting needs to happen. We should be bold. We've known this disease for long. We know what works, what doesn't work. We should shift the tasks that have to go to the primary level so that only the ones that need tertiary care actually go for tertiary care. Mariane.
Well, I agree mostly with Isaac, but I would not accept so easily that hydroxyurea is to be given by everyone and not by specialized and trained doctors. You have seen the difference, and there are different ways to give hydroxyurea. Isaac is living in Canada, very close to United States, and finally you give the American position and American decision. In other settings, we have observed that the very clear protection on brain has been demonstrated for very high dosages of hydroxyurea. The Twitch study used very high dosages. Isaac says you can give low dosages, but we have no data to think that it protects brain. So I think that for most things, you do not need to have physicians but for hydroxyurea, I would make a different answer. Yes, you need to have someone extremely trained in sickle cell disease to decide who will receive hydroxyurea.
So you see the differences there, and the reason why the differences are, I'll tell you the story of Canada. When we started using hydroxyurea, all the pediatricians said this has to be started by a hematologist. And we said, the decision to start, once you have the indications, we can give you the guidelines to follow. We can support you remotely. So I don't have to have the patient come to me. We can discuss this and work with them. So I'm not saying that healthcare workers on their own. We've done this with cancer care. Now it's being shifted more and more into the community with partnerships that is linking care providers at that level with those at the tertiary level. So what I'm proposing is not that they independently operate on their own. I don't think that would be a good system. I think there should be strong linkages that enable that coverage to happen. Because if I were to say that every child that needed hydroxyurea in Ghana should see a hematologist in Ghana, there are only 2 pediatric hematologists in the whole of Ghana. It will not be feasible.
About 25 years ago in the UK, along with some work in the West Indies, we showed a significant proportion of children, young children, with sickle cell disease had enlarged tonsils and adenoids and had sleep-related upper airway obstruction during sleep, producing hypoxemic episodes which could potentially lead to crises. Nobody's mentioned upper airway obstruction. Is this a significant factor, or is it something that was perhaps just a one-off finding?
To my knowledge, it has exactly the same incidence in sickle cell disease populations that in controlled children. But in sickle cell disease population, it is a very well recognized cause for strokes. When we have our children and when we control every 3 months. When you have money, you can control children every 3 or 4 months. We look very carefully about the size of the tonsils, and we perform surgery when they are enlarged. It is a very, very well recognized cause for stroke.
Actually, it's now the commonest surgical procedure we do on our patients. Now that we prospectively actually inquire about snoring and sleep disturbance, and we do sleep tests. Obstructive sleep apnea is very common, and is the commonest reason why we do tonsillectomy and adenoidectomy. And I think there's some, I would say there's probably some explanation for that, because I think if you have the sickle cell patient who's having recurrent infections, and then you have the racial sort of narrowing of the nasopharynx, I think those factors come together which make it very common. So you're absolutely right. I mean, what you saw in Jamaica is now a reason for prospectively looking at for these patients and doing tonsillectomy and adenoidectomy.
Yeah? Oh, thank you. And thanks very much for the presenters. I have not a scientific question because I understood half of the things. No, I'm just kidding. For our colleagues that worked in Kibera, I took note of your Kibera suspicion factor. It had, from my understanding, like a very high positive predictive value, if you want to make it scientific. So which were the kind of factors that were put there, or variables that you were considering? Because it was very high. And I just put it versus what the professor said, that to drop kind of a screening. Maybe you should do something like that and then screen those that have this high suspicion from the Kibera. So I would like to know which are the things that you took into consideration. And then I don't know if I'm allowed to make a question for the chair, Dr. Ousmane, also, from your link also with WHO and all these. Which are the political factors that prevent WHO maybe to be more forthcoming on that issue?
I want to precise that in WHO, I'm just the president of the task force on maternal and perinatal care, not on sickle cell disease. I have worked in sickle cell disease 20 years ago, because I was the first who put in place the first consultation for sickle cell disease. But now it is Professor Ibrahim Ndiaye and others. Now I'm concentrated more in neonatology than the other fields. Okay.
I think that it was recognized by the WHO as a priority health problem in 2006. But it is only a declaration. It is a priority health problem. It is signed on a resolution published in 2006, and that's all.
Well, I have some personal views about WHO and its commitment to that it took so long, 2006, to issue that white paper tells the story itself. The sickle cell agenda was placed in an office for genetic diseases. For many years, that division had no director. And the previous director must have become very frustrated because there wasn't enough support and funding for it. We haven't seen any person emerge from WHO to really champion this. And I worry because in the era of the Sustainable Development Goals, when we are going to concentrate on non-communicable diseases, if sickle cell disease doesn't show up, just like you surveyed the situation in Kenya, and I applaud you for that, in many countries they've drawn their priorities and sickle cell disease is not there. And the global community is going to move on those priorities. The resources are going to go on to these disorders that have been identified. And my worry, my anxiety is that sickle cell disease will be completely lost. So we need to strengthen our advocacy. We need to rally WHO. We need to rally all these organizations to say, yes, it's a genetic disease. Yes, it is lifelong. But there are elements of it that are really amenable to solutions, and we should not forget about it.
Thank you.
I think to answer your question, what happens in Kibera is that a lot of the children we test are patients who have symptoms. So I already suspect. And so one of the things we were discussing is how do we move away from suspecting to actually saying, are there certain people who we need to test within the population? So is it because you come from a certain area, so you're more prone to the disease, so we need to think about you? But for us, it's the fact that I have seen you, you're unwell, and I suspect that it's possible that you have sickle cell disease.
Yeah. On peut s'arrêter là.
Okay.
The last one.
Two small precision. I think, unfortunately, sickle cell anemia, it's not failing in WHO definition of neglected disease. Is one of the reasons is not well promoted. Because neglected disease in WHO should be infectious communicable disease. But now, recently, they made some exception. So we can hope for the future for sickle cell disease to be more under the light in the spot and to drive more attention. The second thing, I think we should push WHO because hydroxyurea is in the essential drug list for adults in the group of oncologic drug, but absolutely not in the pediatric essential drug list, and I think should be pushed for change. So I have a question. I think it's for Mariane, but might be. What do you think? It seems that priapism, it's a very, very painful and damaging problems in young boys. So it might be also David, in your experience, I know. So what do you think we have to do in a low-resource setting, NGO like MSF, with the limitation we have to manage this problem?
In a preventive way, I think that hydroxyurea is an indication to prevent recurrences. When you are in a confronted phase to the complication, I think that you have also some emergent decisions to take, and it's quite technique. You have some drugs which can be delivered, and there is a package of drugs, but also to give education, because a surgery would be a disaster.
Okay, we're going to take the last question because we now have no more time. Okay, the last question.
Yes, it's more...
Just time, yeah.
Sorry, Anya, it's more a question to the MSFers on the panelists and the audience. I'm asking myself if we are doing enough for our field teams to really support them, giving them guidelines enough. I mean, we heard it's complicated still, somehow. But we see that it's very important to train people, to inform people, to do good basic care. And it could be that it's only me, but I experienced a lot of difficulties in actually gaining the information and really doing the right thing. So I think we as MSFers have to ask ourselves as well if we do enough to support our field teams. Thanks.
Yeah.
Well, you're right. All of us are trying to make e-teaching. I have personally made a lot of lessons through e-teaching, and all of us are trying to develop them. But you're right.
Okay.
Yes. I think also in the Kibera program, what we have is we have guidelines. So standardized, simple to follow protocols that can be used by the clinical officers and nurses to manage patients at our level, whether it's health center or dispensary. And then it clearly says who do you need to escalate and who do you need to keep at your facility.
Was that the last question?
Okay.
Okay.
The very last question. Huh?
Okay.
Okay.
No, so just to answer your question, I also think we're not doing enough. So in that way, I'll try to wrap up with some of the key conclusions. Okay. So we saw that simple interventions, including guidelines, education, immunization with pneumococcal vaccine, penicillin prophylaxis, malaria prevention, nutrition support are feasible and are not yet well implemented, and can really have a significant impact on reducing the burden. We need to be smart and innovative. So prenatal diagnosis may not be feasible, but on the other hand, point-of-care testing at all levels of the healthcare system would be. And so we should really think about integrating the diagnosis and the management of sickle cell disease at primary healthcare level. Hydroxyurea is very promising and may even have a bigger impact in these low-resource settings where we don't have access to transcranial Doppler. And we could explore simplified models of bringing treatment with hydroxyurea to scale. We should remember that giving a test is not enough, so education is very important. We have to tackle the myths and also the fears surrounding this disease. We should remember the patient-centered perspective, to listen to the patient, and not to forget also about the pain management. And finally, we need to strengthen advocacy. So there is really a role for the Access campaign to help us with this. And I hope they will to help us advocate for the point-of-care test, less than $1 a test, and also to help us advocate to put more focus within MSF on this neglected disease. Okay. So I think that's it for...
Okay, we can say thank you to David, thank you to Mariane, thank you to Lili, and thank you to Isabel.